Good morning, everyone. We're going to get started. Thank you. Good morning. My name is Nicolette Louissaint. I serve as the Executive Director of Healthcare Ready, which is a national nonprofit focused on issues of sustainability, resilience, and disaster preparedness and response. It is in that role that I am very honored to be here with you all this morning and to join this wonderful panel of experts. We're going to be discussing sustainable, healthy communities and taking some time to really think about what goes into that, and especially in the role of, in the age of so much technology and advancements as it relates to data and data science, how we can use that to improve sustainability. So first, it is my pleasure to introduce Dr. Carla Boutin-Foster, who serves as the Associate Dean of SUNY Downstate, the State University of New York, in the Office of Diversity in Education and Research, correct? Formerly known as the Office of Minority Affairs? Yes. Also, she is a graduate of SUNY Downstate and completed a master's from Cornell Wheel Graduate School. And so I'll turn it over to you to present.
Yes, thank you. Good morning.
Good morning. Morning.
Okay, great. And I assume, is this my friend here? No, it's not. Green to go forward. Okay. Not going forward. Oh, yes it is. Okay, so good morning, everyone. Thank you so much for inviting me here to speak with you for a few minutes about our approach to sustaining healthy communities at SUNY Downstate. So how many people have ever heard of SUNY Downstate or the State University? Okay, good. Because people say like, SUNY Downstate, what is that? So the State University of New York at Downstate, SUNY Downstate, is the only academic medical center in Brooklyn, where we have a population of approximately 2.6 million residents. And our population at SUNY Downstate, we care for a community that comes from neighborhoods such as Flatbush, East Flatbush, Bed-Stuy, Crown Heights, Brownsville, and East New York. And these neighborhoods, while they're culturally vibrant, wonderful communities, they do disproportionately suffer the burden of social determinants of health. So at SUNY Downstate, we like to think of ourselves as the community that we serve, right? So we train a healthcare workforce that really reflects the Brooklyn diversity. 25% of our medical students are born outside of the US. Over 40% are first or second generation Americans, and over a third of our students belong to groups that are underrepresented minority groups. And our students are often the first in their families to become physicians. So in order for us to sustain healthy and resilient communities, it's important that we address the social determinants across a spectrum of activities in our educational curricula, in our patient care practices, and research activities. So this is a slide from the CDC, and you're very familiar with the social determinants of health that disproportionately impact communities of color, including access to healthcare, access to resources, education, employment status, environmental factors, income, insurance coverage, housing, segregation, transportation, and racism and discrimination. And the last category is something that we don't often discuss, but it is important that we keep this in mind when we talk about social determinants of health. Okay. So this is a slide that's been gathered from the Department of Health Community Health Profiles. So this is data from their data set. And as you see, the communities that we care for at SUNY Downstate compared to a more affluent community where the incomes are higher in Park Slope, same Brooklyn, right? Same borough. And you can see that communities such as Brownsville, Bed-Stuy, East Flatbush, Crown Heights, and East New York is closely mirrors those communities. You see that there's a larger proportion of racial and ethnic minorities. Up to 53% in some communities are immigrants. Up to 40% live below the federally poverty line. There's a greater proportion of people who are unemployed, who have less than high school degree, who do not have health insurance compared to Park Slope. There's a greater proportion of comorbid conditions, smokers, obesity, diabetes. And if you look down at the last two rows, you'll see that the rates of violence, right? Violence and incarceration are up to 5 to 6 times higher in the communities that we care for at SUNY Downstate compared to other communities. And if you look at the last column, I think this is what it comes down to. this matters, right? So the mortality rates in Brownsville are lower than that in Park Slope. And there's an interesting slide that, that you can find online that looks at mortality rates and life expectancy if you go across the city, across the train. So if we take the number 2 train or the number 5 or 6 train in East Flatbush, 5 train in East Flatbush, and we get off on the Upper East Side, your life expectancy drastically changes. And these are the things that are important to us at SUNY Downstate that we as an academic medical center view. I'm still not getting this green goes forward thing. Okay, so in terms of sustaining a healthy community, sustaining healthy communities, this really requires a sustained diverse workforce. And we start from a very young age. We partner with 4-year and 2-year colleges. We start attracting students, getting them interested in addressing the healthcare in their communities from high school. We have Dr. Wayne, is Andrew Morrison here? I just saw him. So just shout out to Mentoring in Medicine. Dr. Holden, who also works with Mentoring in Medicine, has been a very strong part of this. So a lot of the students that I see when I'm interviewing for medical school, they said, had it not been for Mentoring in Medicine, we would not know about this. And he didn't ask me to do that. That was free. So we attract a diverse workforce. We integrate social determinants of health. So we have students in high school, and we show them some of the slides that I just showed you, and we said, now you live in these communities. Help us find the solutions, right? So that's investing in the communities early on, because these are the individuals who are going to stay in the community and help to sustain the education and research and care practices to help sustain the health of the community. We also have academic career development for our faculty. Okay. So this is an example of a program that we have. It's called HEAL, Health Equity, Advocacy, and Leadership. This is a program for medical students, and we start to get them interested as they're learning physiology, anatomy, immunology. We also want them to understand that the rates of diseases that they're seeing, it's not by accident. There are true factors that underlie these disparities, and it's not only genetic. It's not only genetic. There's not always a gene that can explain this, and we have to look at the gene-environment interaction. So the students learn about this. They go through journal clubs. They meet with community partners. They meet with local representatives, and we try to foster community capacity by having community members actually teach and moderate some of our journal clubs. Okay, so this is an example. We really support, and sustaining healthy communities requires vocal advocates. So we want our students to be advocates. And this is a picture of our students doing what students do, right? We were very fortunate and blessed to receive a National Institute of Minority Health Disparities endowment known as Transport, Translational Program of Health Disparities Research. And what I enjoy about Transport is that this starts to put the social determinants of health in the laboratory, so that the basic scientists are speaking with the public health researchers, and our students and faculty are involved in this. So we have to understand some of the genetic contributions that interact with environmental factors that lead to poor health in our communities. And this is part of sustaining healthy communities, so that we understand factors, environmental factors, stress, how these factors interact to contribute to the higher rates of more aggressive and early breast cancer and colorectal cancer and prostate cancers that we see in our communities. So our basic scientists are also part of the solution. We recognize community academic partnerships, and just for the sake of time, I'm just gonna go down to the last 3 bullets. We go where our communities go, right? We go to the barbershops, we go to the faith-based institutions, we go to the community organizations. We speak the language, not only linguistically, but socially, politically, and culturally. We understand, we try as best as possible to understand and to engage with partners who can help us understand, because as academic institutions, we don't always get it. Right? So we need to speak to stakeholders so that they can help us. Community academic partnerships is bi-directional. It involves co-learning. We do not always have the answer. And I think it's important, if we're trying to sustain healthy communities, that sometimes we let go of our egos and we allow our communities to really instruct us and guide us on how we should approach this. So this is you're going to hear from Dr. Marilyn Fraser this afternoon, but much of the research infrastructure is provided by an NIH-funded community academic infrastructure where it's SUNY Downstate, Arthur Ashe Institute, and the Brooklyn Borough President's Office. So this really requires partnerships, and this is the list of investigators at the health center. So this is what we do. So we have a number of projects that are going on that engage the community, and that's important to sustaining the community. So we do, Dr. Fraser does a lot of work in barbershops and salons, educating salon owners and stylists and barbershop owners to be the educators, the interventionists. So they do a lot of these interventions, whether it's HIV education, weight loss, colorectal cancer screening. Dr. Joe Ravenel at NYU, he did a project known as Mr. B, where barbershop owners were trained on colorectal cancer screening and blood pressure assessment so they can then intervene and interact with some of their clients. Faith-based institutions, we've gone to faith-based organizations and trained lay ministers on weight loss and mental health. And we're also partnering with community-based organizations around breast cancer screening and disabilities and health promotion for non-custodial fathers. And this last row with CBOs provide special service, this is something that we would not have done had we not listened to the community, right? So when we talk about breast cancer disparities, we don't think about the disparities that occur even if someone has health insurance. But for women living with physical disabilities, if they cannot get into the suite, if they cannot access the machine, then that's the disparity right there, whether or not you have health insurance. And it's speaking with the community and going out there and looking at women as they try to navigate the systems. That's how we learn. And the last one is health promotion for non-custodial fathers. So we wanted to do an intervention on weight loss among Black men. We partnered with Dr. Torian Easterlin from the Department of Health, and he brought his partnerships on fatherhood, and they said, y'all not listening to us, basically. You know, if you look at, you're trying to interact and intervene with Black men, but Black fathers have not been part of the picture, even though they're Black men. And we're like, what are you talking about, right? So he said, no, just Google Black fathers. And we did that. And what do you think came up? A lot of negative things, right? About the absence of Black fathers in the community, where there are studies that have been done that shows that Black men are indeed, in fact, involved in the lives of their children. And so this is listening to community partners help us to address what really matters to them. And I'm getting the gong show, Apollo, get out. So this is just a pictorial of what we do with the community. And Dr. Frazier is going to talk about hiring community partners to work at our institution. And so that's basically it. We really listen to the community. We go where the community goes. We listen to their voices, and we learn from them, and then that helps to inform our interventions to sustain the community. Thank you.
So now that we've heard about academic medical centers and the way that they engage, I'd like to turn the floor over to Dr. Jay Bhatt, who is the Chief Medical Officer and President of the Health Research and Educational Trust at the American Hospital Association. In this role, he oversees AHA's clinical leadership and health improvement activities, and is a practicing internist who has trained at the University of Chicago, Philadelphia College of Osteopathic Medicine, and has an MPA from Harvard's Kennedy School. Jay?
Great. Thank you so much. Good morning.
Good morning.
It's great to be here with all of you, such amazing contributors to transforming the health of our communities, and really grateful for the leadership of Dr. Puckern and the NMQF team. I always look forward to coming to this meeting. And Congresswoman Donna Christensen is in the audience, who I was grateful to work for and learned a lot from about how we think about these communities and how we move the needle on where they need to go. And so I'd start by saying that health disparities has become America's chronic condition. It is something that we see not only in hospitals and health systems, communities, we see it in the ways that we interact with our peers, we see it in my own practice, and I think that we've got to do something different in order to shape the community to be both resilient and sustainable. And so the American Hospital Association since 2017 has been on a journey to really do something called redefining the H, redefining what the hospital and the health system look like and what their role may be. And advancing health in America is the new strategy, with the vision of a society of healthy communities where each individual has their highest potential for health. So not just thinking about health care, but health. And that there are 5 commitments that reflect that notion, that how do we know that we're making progress on that vision? We have to be moving the needle on these 5 commitments of access. So, and specific words are associated with each of these commitments. And it took a year with conversations across the nation with nearly representatives of communities across 5,000 hospitals informing these particular commitments. So affordable, equitable access to behavioral health and social services, value, bringing care that delivers value to people's lives, partners, embracing the diversity of individuals and families as partners in health, well-being, so partnering with community organizations and an understanding of that to get to well-being, as well as coordination, care, using teams, data, technology, and innovation to help improve the health of communities. And so, it's going from a hospital to health system to a health organization, and how part of my role is in our work that we do leading the Institute for Diversity and Health Equity, as well as our population health efforts, is to help our members make this transition. And so when I think about the different ways that can happen, one is in place-based changes. So Metro Health in Cleveland, for example, is moving from 2 acres to 25 acres, and they're creating something that's called a hospital in the park. Wellness trails, redesigning the campus around them, bringing different approaches to resilience and sustainable communities in the place they occupy. The other is understanding the community's voice in addressing what's happening. So community health sometimes has been directed by the institution, but in Richmond, Virginia, and church in a neighborhood there that was very poor, the community spent a week with members of the delivery system designing and understanding what the needs were. So the organizations may have thought it was transportation. What it turned out to be was unemployment. And the community told them it was unemployment. So the 3 hospitals in that community invested $50,000 each for 3 years into 14 startups, small businesses that were generated by the community. And now, a number of years later, they have become one of the top 10 rising communities in America. Those 14 businesses are still active, and the health of that community has been transformed. The other is unlikely partnerships. So in Charlotte, North Carolina, Novant and Carolina's healthcare system, now Atrium Health, found that they had 6 zip codes in which individuals were coming to both Novant's emergency room and Atrium's health emergency room. And so the CEOs actually said, this is not a problem we should be competing on, that we should actually solve together. And so they did asset mapping using data to understand what was happening in the communities and went with their teams into the communities and had conversations with them. And so what resulted was not only a systematic structured approach to addressing the social influences in those communities, but also investing together in access, because the access point was challenging for those 6 zip codes, and that's why they were using the emergency rooms as places that they could get care. And so they invested together in an access point that has shared ownership, shared governance, shared strategies, shared revenue, and the community plays an important role in that. The other is this piece about data, and data has become an increasingly important asset to help transform the health of communities. And so, for example, looking at data of populations of color in Seattle, Tacoma, 50% of the African American population went to 5 hospitals. And so if we were to actually drive change in those 5 hospitals and the communities that they serve, we can move the needle on that population. And just recently, we're continuing to see such an important conversation of the stark disparities that exist in maternal mortality and infant mortality. And that has implications for race, the challenges that communities face over time, and that we've got to think about how we invest in children. And at the ages of birth to 5 and the languages that they get exposed to. The other is partnerships, clinical and community linkages, and novel partnerships to address diversity, inclusion, and health equity. And so as we think about unconscious bias as something that has to become an important part of our work, but also that we haven't moved the needle significantly on leadership and governance that reflects the communities they serve. And so we last year launched a partnership with the National Urban League, which is an unlikely partnership with the nation's most influential hospital health system industry organization partnering with the nation's largest civil rights organization to move the needle on three things. One, diversity in governance and leadership. So we connect Urban League leadership to hospital and health system CEOs to populate their boards so that the voice and picture of the communities is in that conversation. Two, we're working to embed and train community health workers as part of hospital health system delivery teams. Because the question was, they were having trouble placing them in the delivery environment. And part of the challenge is because predominantly the delivery system doesn't know how to use them effectively as part of care teams and understand the return on investment, both from a outcomes perspective, a long-term health perspective, and a cost perspective, because we also know that affordability is one of our biggest issues. And three was having the conversations with the Urban Policy Solutions Council and talking about some of those issues. And so we're going to be in the next few weeks launching another partnership with Unidos for the Latino community. So these are different ways that we're thinking about redefining the H and addressing sustainable communities, and look forward to the conversation.
Now it's my pleasure to introduce Dr. William Carson, who is the President and Chief Executive Officer of Otsuka Pharmaceutical Development and Commercialization. He leads a team that develops new products for market entry across a range of products, and is a board-certified psychiatrist trained at Harvard University and Case Western Reserve.
Good morning. Thank you, Nicolette. I'm going to take the conversation a little bit astray from where Carla and Jay talked. Otsuka had the great fortune with our partners Proteus in November of last year to have the first FDA-approved digital medicine. The drug is called Abilify MySight. You heard a lot about it. It's the chip in the pill technology, Big Brother taking control of how you are taking your medication, but it's not that. Let me tell you what it is. It is an embedded device inside of an Abilify tablet. It's about the size of a grain of sand. And when you take it, it hits your stomach, and at that point in time, it sends a signal to a patch. And that patch then sends a signal to the cloud, and it comes back to your phone. And it's the first time that physicians will know that patients have actually ingested their medications. So the first digital medicine. In 38 years, the FDA has not had a new class of medicines or a new class of drugs that they've approved. Now, the challenge, as most of you could imagine, is that everybody really wants to talk about, well, what does that mean? And how are we going to use it? And what have you learned? And it really actually links back to a bit of the conversation that Jay was talking about. One was the inherent stigma attached to Abilify and having a chip in Abilify and what you would do. So the question I get asked most often is, why are you picking on those poor patients with mental illness? And my response is, that just represents the stigma that you're bringing to the question. Because patients with schizophrenia, bipolar disorder, and major depressive disorder are some of the patient populations that have the worst issues with regards to noncompliance and the worst outcomes when they're noncompliant. So why wouldn't they be at the front of the line for this new technology? The FDA, their interest was, could those patient populations actually utilize the systems? Did they have cell phones? Would they be able to download an app? How could they get a patch on? And would they be able to follow the systems? Actually, all of those questions are true. It's surprising. One of the things that we learned was sometimes the last connection between patients with mental illness and their families is the family provides them with a cell phone. If you go to Union Station, you'll see them because they're all plugged in because they have Wi-Fi and they can get in touch with people. And it's pretty remarkable that this patient population would be able to do those things. And the other issue that comes up is with regards to what do you do with the data? The patients have to opt in. So at that point in time, they will say, if they want no one other than themselves to know that they've ingested the medication, then no one else will know. But you can allow caregivers, your doctors, and your family to know. And I think that all of those things together really help with regards to making sure that patients continue on their medication. Now let's think about data transformation and what does it mean for communities, what does it mean for our communities. To get this approved through the FDA, the Proteus product, the technology was already approved, Abilify was already approved. So you took two approved products and put them together. So basically, we only had to do how would you be able to use the system, about 300 patients. But the data that's collected through the system is continuous data down to the minute. So the amount of data that has collected in those 300 patients, I think Nicolette said it earlier, I'm responsible for the research and development of all of Otsuka's compounds. The data from this program generated more data than all of the clinical trials that Otsuka has ever done. So what we are moving into is this age, I call it the data tsunami. The amount of information that you get on people, every minute we know whether or not the patient is sitting, standing, lying down, moving, every minute. And the question that you have to then do is, what do you do with that information? How do you make it helpful? And trying to put it in the context of this conversation, we put together a panel of bioethicists to help us with regards to understanding what do you do. And what would you imagine is the number one concern that was raised with the bioethicists? And it was by doctors. And doctors said they did not want one more piece of information that they had to act on. So this is going to be our dilemma as we move forward with the product, is how do you take the information, make it useful, make it so that the patients will be able to get help from it, make it so that their families can get help from it as well. I think the other piece, and maybe the more important piece with regards to sustainable communities, is making sure that our communities are represented with regards to data and data generation, data collection, data use, so forth and so on. All of the algorithms that you hear that line up behind the data, actually, the challenge that you would have is, are those algorithms themselves biased? And what we have to do is make sure that we stay on top of that as we move into this era, because Carla raised questions earlier, Jay raised questions. Every piece of things that they're talking about, every little piece, there would be data that's behind it, and that data will be utilized to make decisions about which hospitals stay open, which communities get care, and the challenge is, are we all ready for dealing with this data tsunami? Thank you.
So thank you all. I think it's been great to hear your perspectives across the range of thinking about hospitals and health systems, individual communities, and then thinking about really this question of providers and thinking about how we actually deal with the individual patient, and this question of what do we do with all the data that we have. So since that is a complicated question, I'm going to jump to that last. And let's actually start with thinking about a little bit of level setting around the composition of these communities. Who are you've all talked about partnerships in different novel partnerships and unlikely partnerships. who are the key stakeholders that need to be in these conversations and in these efforts in order to really move the needle? Jay, I'll start with you.
So I think that it needs to start with those that live in the communities and their families, their caregivers, and then it's if you think about the notion of a chamber of commerce and what the chamber of commerce does in communities and how it brings together the business community, and I've been talking about this notion of a chamber for health, and so this notion of who are the stakeholders that come together around health, and that's at the center the community members, but then it's your community-based organizations, it's your employers, it's your small businesses, it's your technology companies, entrepreneurs, it's your it's people that have been affected by the vulnerabilities that communities have faced, and those real stories that we see. I got my start in public health in college when I went to get my hair cut, and I met black men and barbers in the south side of Chicago that I struck up a conversation with and learned more about the challenges they were facing. And over the course of 5 years, by putting a clinic in the back end of that barber shop and saying, if you want to get your hair cut for free, then you got to be seen by the doctor, it motivated education and learning and change in a way that not only improved their health, but they started helping each other get jobs, which was a big issue in that community. And so part of it is we don't know what we don't know, right? So what questions are we asking and what venues are we creating to have the kind of conversations we need to create these novel partnerships or unlikely partnerships, but also address the unconscious bias that we all live with. We come to life with our loyalties, our disappointments, our ancestry, our history. I've been talking about the notion of unconscious digital bias, and to the point that was raised about these algorithms have the predictive analytics, machine learning, and natural language processing embedded unconscious bias in it. And so we need to filter what comes out of there as before we make decisions, and not just take it blindly.
I actually think I agree with you 100%. And if you talk about partnerships, I think one of the places to partner is in communities bringing in technology. So the challenge, and you all are very aware of this, the most amount of money that's being raised now from a venture perspective is with regards to healthcare. So it goes through the roof. There's a startup healthcare. These are the people behind the moonshot. In the last 3 years, they've raised $800 million for startups in the healthcare space. So the question is, what for communities is that $800 million going to? I met this young brother, his name, it skips me right at this point in time, but he's about 24, and he's doing literature for patients who have diabetes. And Startup Healthcare is helping him to move forward. His company's called KingFit, so I do remember that part. So if you look up KingFit, you can see who he is. And I think what we have to think about is how do you tap into those investments, but how do you also make sure that you get more 24-year-old young people of the communities doing things that can tap into that and help those communities. So I think something around the barbershop, something around the churches and faith places would be a very good place for that kind of linkage with tech.
And I would add, also, when we think about stakeholders, who do members of our communities listen to? So as Jay said, they will listen to a barber. I had an example when I went to get my hair done, and women were talking about fibroids. And they said, well, you can't go to the doctor to get your fibroids checked because they're going to take out your uterus. And I said, well, actually, no, that's not the case. And they're like, she doesn't know what she's talking about. No, you don't know what you're talking about. Just sit here, get your hair done. We know what we're talking about. So who do people listen to? Really, is it the barber? Is it the hair salon? Is it their religious leader? So is it music? I did some work with youth.
And I realized that they weren't listening to me, but they were listening to Jay-Z and Biggie. So using the language, so when I spoke about meeting people where they are and speaking to them linguistically, culturally, and politically, the media, so getting people who are involved in the media to help us to speak to our community. So who are our community partners listening to? Those are the stakeholders.
I would say another group that I think we need to think really hard about how to do this work, and I know some folks are doing it already, is the payer community. And that's both employer-sponsored payer, but also the other commercial payers as well as Medicare. So we see the accountable health communities approach, but again, the longitudinal data isn't there. Folks are going to different places. But we've been working with both Healthcare Services Corporation and Cigna on thinking about the issues related to disparities and equity. So we've got an equity of care campaign in which all 50 states have signed on to, and nearly 1,600 hospitals to try to address. And now we're working with payers to help provide incentives and performance support for organizations to do that work. So I think that payers can play a really important role in this conversation. And so we got to think about that.
I also think we have to remember that digital transformation democratizes everything that we do. So it can push it down to the level of the patient themselves if they have the resources, meaning things like wireless, and they can connect together. So an interesting part around fibroids would be, I'd love to see those conversations happening online where people could then connect into communities so that they could share stories on what they know or what's best and so forth. And that's the democratization that you're talking about. There's a group of women, I think it's in Los Angeles, and it's called Women Walking. And what they utilize, they're online, it's women of color, and they actually basically touch base with each other and say, I'm walking today, do you want to walk with me? And so this community has been built around doing just that. So again, you can democratize your health down to a level of the individual, and you now have the systems with data to be able to do that. In the work that we've done with Silicon Valley, the big terminology now that you're hearing is called disintermediation, which is a huge word, and it just basically means taking out the intermediaries. So in essence, you go directly to the patient, or you go directly to the person, or directly to the service, and you don't have to go through the doctor. And that is where things are moving at this point in time, because that's perceived as being incredibly powerful and also incredibly useful.
So before I jump to the next question, the hashtag for today is NMQF Summit. So jumping into this conversation about data, I actually first want to start with the question of data stewardship. So we can access a lot of data, we can collect a lot of data, but thinking about the issue of stewardship and how it can be used, I believe, and even in our organization, we've been able to use data as an amplifier for community voices. If we can figure out how to collect the right data, deal with the biases that may be in the data, and then disseminate it in a responsible manner. But this question of stewardship, I think, is really important before we get to how we can use all of the data we can collect. I think we have to think about what we collect, how we manage it, how we allow the patient to retain some level of control. We're in a time now where CVS can send you a text message and say, remember that your prescription is, ready for pickup in a couple of days, or before a disaster, for example. We'll be able to work with pharmacies who can say, these are the patients that need medicine before this hurricane hits. So that's one example. Now we're in a space where patients can take a pill, and their caregiver can know whether or not they took their pill. So this question of stewardship, I want to dig into that a little bit more. What are your thoughts on in order to really move the needle on sustainable, healthy communities, what is the data that we need to collect, and how do we deal with responsible management of that data?
I think community engagement is really important. So our communities have to know what we're collecting and what we're going to do with the information and how we're going to disseminate it and where we're going to disseminate it. So I think part of data stewardship is understanding, once you get the data, who will you disseminate the data to? And we often publish and disseminate it to each other, but not necessarily giving it back to the community and asking them, is this how you would interpret our findings? Because we have our own interpretation and we disseminate it through that lens, right? But having the communities look at our data and say, well, actually, this outcome, we didn't measure stress, we didn't measure perceived racism, we didn't measure these factors, so therefore the interpretation of the data may be skewed.
From the academic perspective, it's rare to see researchers go back after a study and say, here's what I found, or here's what the results are, or actually ask, how would you interpret this? And growing up in East Flatbush, and knowing that there were a lot of studies that were going on in the community I grew up in, I never saw researchers come back with the results. So I never thought about the idea of being able to continue that conversation and say, here's what we collected, here's what we found, what do you think?
No, that it is a challenge, so I'll let.
I would add that one of the things, and I think we need to think about is a common language for stewardship. I think what stewardship means for different stakeholders and audiences was different. So, for one community, it might mean one thing, another community, another stakeholder. And folks use data as an asset in different ways, but they'll also use it to achieve objectives that you might have. But I also think this piece about closing the loop that you raised is really important, and that how do we get the data from places that we don't have to help inform a conversation. And there's qualitative and quantitative. This community visioning process I was talking about earlier is one way that you're getting that qualitative data to them and inform direction. And in human-centered design, you're seeing emerge into healthcare and the intersection of health and design. I think human-centered design is a really important way to hold a structured, complex conversation, but also think about the end user in that process.
We heard a lot last week with Zuckerberg in front of Congress about the GDPR, and these are the new European regulations that go in force at the end of May. And one thing that he said during his testimony was that Facebook would be using those rules despite the fact that they're just for Europe. But what it allows any European to do is anyone who holds your data, you can go in, see your specific data. You can eliminate the data, so you can get rid of it completely and say, I don't want it to be shared at all, or you can correct the data. And companies are doing lots of work to get prepared for the GDPR. I think for us and our communities, it's really important for people to be aware of those types of regulations. I'm not suggesting that anyone push for America to have exactly the same regulations, but it would be helpful for people to know. And if you have companies defaulting to the more strict European rule, then it means that you can probably go in and get the information in the same kind of way. I think one other thing which Carla raised was the challenge around what patients do or how they get their data. There's a big push towards individuals having their medical records all the time in some sort of format. And I don't know how that's going to play itself out, but I do think that within our lifetimes for sure, but probably within maybe the next 5 years or so, everybody will be walking around with your own medical record in some way, shape, or form. So when you show up at the next visit, they don't have to worry about going to all of the different places you've been. All of that information will be there, and the person that you're seeing will be able to see everything. And I think that the question there, however, just because you have it doesn't necessarily mean that it's accurate. And so the thing for everybody is, how do you make sure that that the information is accurate and reflective of what has happened to you, and how do you also correct your electronic medical record when you're able to do that?
So now let's think about all of the opportunities that big data has. One important point that I think you've all touched on is, how do you collect data from unlikely sources? There are forms of data that are easier to collect if you have greater access to technology. If you are going to the doctor on a regular basis and have electronic health records, but how do we collect data from everyone? How do we collect the data that needs to be collected, or deal with the issues of this access issue and the kind of the nexus of access and data, to make sure that we're collecting all of the data that would help us to inform what these communities have as assets and need as support? And what do we do with that? What's the action that we take based on having all of this data available?
I'll jump in only because when you were just talking about that, it popped into my mind. Tom Insel, who used to be the head of the National Institutes of Mental Health, he went from there to Verily, Google, the healthcare part, and now he has his own company called MindStrong. MindStrong is one of several companies that has. Now, what can you do with MindStrong? The company's whole basis is on how you interact with your cell phone, and it can, how you swipe, tap, the number of times, so forth and so on. And the premise is that they can tell a depressed patient, major depressive disorder, from a non-depressed patient, just on how you interact with your phone. So, this whole concept of how do you collect that data, we're collecting tons, each of us who has a smartphone, tablet, whatever, we're collecting tons of data. Your provider knows where you are right now. They can tell you we're all in the Ritz-Carlton. They all know that. And that's because you're carrying it with you. And if you have your location piece on. So I think that where you have to start thinking is about, yes, it can be used for good. We have to be concerned about how it might be used for bad. And so I think that's where we have to really step in and defend our patients and our communities, because you might actually end up sort of dismissing whole groups of people because you know where the data came from, and I'm not going to look at it. So I think in our conversations about equity and inclusion around healthcare, I think we have to continue that same conversation around the data attached to health for equity and inclusion as well. Because if you don't put all of it together, you're not going to have a complete picture.
Yeah, I would echo the points certainly around unintended consequences and considering data and its implications for the populations that are most vulnerable. I would also think about the race, ethnicity, and language data that is so important. We don't collect in a systematic way consistently across the board. So how do we help improve that? The continued support of class standards, and also thinking about place-based data. So now so what are the most high impact opportunities in particular communities, and using the data to drive targeted intervention. So like the piece I talked about the population that was in this small set of communities, or using technology on top of an inhaler to understand place-based implications for asthma or COPD, so that you can then intervene in communities that way. And I think we got to also think about systematic approaches, because community health, social determinants, all that, we've generally not in the delivery environment applied a systematic approach. So we hospitals and health systems know how to do quality. They're getting better and better, and we've done that for 10 years. But the reason why it's been so successful is because I think we've applied a systematic, data-driven approach to it. And so we need to, what does that look like for the issues around the social determinants of health and others? So systematic screening, evaluating that data and acting on that data is important. And so, AnMed Health in South Carolina, for example, has their language translation services as part of their safety huddles every morning, because inequities lead to patient safety incidents. And so if you're not understanding the missteps in translation, language translation, in a systematic way, then you're missing opportunities to create equity.
And I would add, using mixed methods to complement big data. We haven't looked at that because you're going to have a whole host of data, but to understand it in the context, and the best way to do that is to, again, to close that loop and to go back to the community and say, this is what we found, help us explain this. And the application of quantitative and qualitative data together in a mixed methods approach really helps to sort of give the full narrative of what we're seeing, because numbers are just numbers without the words to help us explain what's happening. And I think community partnerships and using photo voice, qualitative interviews, focus groups can help us to really better understand what it is that we're collecting.
One of the aspects of being in the space and having resources to do different types of research, we actually recently gave a grant to the Harvard School of Public Health. They have a whole division that looks at environmental sciences. And so it takes there's sensors inside of rooms, and the head of that group actually made a comment which I had not really thought about. He was like 42 years old, and he said, well, do you realize that I've spent 36 years of my life indoors? And so that's for everybody. And as a physician, as healthcare providers, do we think about the environments that our folks live in and the impact on health? And so this is really getting at the idea that if you're ignoring where people live when you think about what it is what they're dealing with, then you're missing one big piece of the pie. So we're doing some work with Alzheimer's patients, and then what we're going to do is to see whether or not, with this grant to the Harvard School of Public Health about environments, whether or not the environment in which these elderly people live impact the response to medication. So, I never really thought, as a researcher, as a psychiatrist, that I would be thinking about, looking at environments to see, could you see something? And then the next piece would be, if you do, then how would you do something with that information? So yes, I think that, and the only reason that we're able to do that is the ability now of crunching so much data, and then the next part, having the speed to do the analysis attached to it. So we are pushing ourselves into a place where we've never been able to, we could do it in a very simplistic way, but for us to gather information about air quality, information about the paints, the VOCs in the paint, or what's in the carpets. And one of the more interesting aspects of that kind of conversation is you could make rooms and spaces better quite inexpensively, but someone has to decide that they're going to spend the $1 or $2 or $5 more per square foot to be able to do that. But when you think about communities that are at need, we're just worried about trying to keep a roof over people's head, not the quality of the space there. We're just trying to keep them in some sort of shelter. And I think we have to push our knowledge down that way as well, because I think what it does emphasize, it will emphasize the public health crisis we have around where people live and how it impacts their health.
So we talked about About partnerships, we've talked about data. We've touched on investments in infrastructure a little bit as well. So I want to kind of pull those together to think about resilience. If you'll indulge me for a few minutes, disaster response is my world. So I often think about how communities can work together in the context of being able to respond to shocks. So if we're thinking about I love the Metro Health example that you gave. If we're thinking about communities that are in need or communities that are in crisis, what are some of the best practices we've seen so far that you all can speak to that help us to see examples of what it looks like to have a community that is okay in blue sky, but able to respond to the gray sky or the black sky events as well? Are there any examples you?
I would, just by drawing upon what the country has experienced in the last year with the kind of disaster that's hit our shores and the way that, we've seen hospitals and health systems play such an important role in being a place that communities go to. But I think we've got to, as a group of people, do better in longitudinal support. And so there are some places that are very intentional about longitudinal support of those folks affected by trauma. So not just in the acute phase, but 6, 9, 12 months, and that the community is involved in a different way. And there's an incident command system for the community. So who gets activated as a result of these different shocks that hit communities, and then how they get better from it. There's just such strong inherent resilience as we see within people. And sometimes we are in situations where that resilience doesn't come out to its full potential. So creating those environments. And I like the example of the redwoods. I don't know how many of you have been up against a redwood, but it's towering structures, right? 100 feet, and they withstand so much from all that comes at it. And so I asked them, why is that? And part of you think about how deep are the roots? Anyone know? They're sort of 6 feet, 6 to 10 feet. Those are pretty shallow roots for a tree like that to withstand so much. And the reason why it does is because the roots are interlocked, even at that level. And so the tensile strength relies on each other. And so because of that, they're stronger together. And so as we think about this work that we have to do on resilience, how do we connect those sustainable, interwoven connections among people and communities and organizations and institutions in communities so that we can withstand that all that comes at us, but also have the longitudinal support that's needed?
I can answer the question with two different hats. One of the hats I wear is president and CEO, so I have to think about keeping the lights on and all of those kinds of things as far as the business is concerned. And in crises, we learned a lot. I obviously work for a Japanese company, and in the big tsunami a couple of years back, the Japanese were much more quick with regards to being able to get answers about all of their employees, and basically they have phone trees, and so every manager was responsible for touching base with each of their people, and within less than, say, 6 hours, it was clear that no one had been killed. So now, you saw how big the disaster was, but they had it all planned out. And we actually, since then, have globalized sort of this emergency preparedness. And with the way the weather was last year, our new process around checking in with people is, we immediately want to know, who do we have in the areas? Are they okay? Do they need shelter? Those kinds of things. So we actually reach out to make sure all of that happens. And I guess that would be one of the first things I would say is for organizations, for institutions and so forth, really look at your emergency preparedness in the context of, can you actually find people when something like that happens? Another tip that we learned from Japan during that tsunami was that don't try to call because the phone lines will be down, but you could get text messages, which was it was the first time I ever thought, like, really, I can't imagine that people could answer back. I don't know why the line, I don't know why if you couldn't get a call in, you'd be able to do the text messaging, but texting worked very, very effectively during the storm. I'll put on my other hat, which is the researcher's hat. So now, when you're doing these large-scale clinical trials for registrational approval, the data, you live and die on your data. And the last thing that you want is a big gap in your information because of a disaster. So you have to then explain to all of the people around the world, why did I lose this whole set of patients? So on the research side, since we know where all of our research sites are, we do the same thing to check, do you have active patients? And then are we able to get the medications necessary so that the person can continue in the trial? For the last time for a big disaster where we actually lost tons of data was around Katrina. And so I think all of the New Orleans sites were down, and all of those patients had to stop the study, and all of that data just stopped. So part of the challenge was, it was clearly a horrific scenario, but it had implications far downstream. Who would imagine that a hurricane would end up with a big hole in a data set for a pharmaceutical company from a registrational perspective?
When I was thinking about resilience, and we often think about it in the context of natural big disasters, but I often think of it as responding and bouncing back to sort of the daily stressors that communities of color often face, whether it's racism or violence. So in essence, the communities are resilient because they're bouncing back, especially in this climate, on a daily basis from an onslaught of stressors. So I think one approach is to really ask people, how did you cope when this happened? And who did you turn to? And we find out that it is the barbershops, it is the faith-based leaders that they go to, and then going to these settings and building those settings so that they can be sort of the haven that people go to. Because this is where people go to, again, on a daily basis. So looking at how do people deal with daily life events and leveraging those resources and supporting them so that in the face of natural disasters that they're already strengthened. So we're not waiting for something to happen for us to really leverage some of our resources that already exist in the community. So just ask people, where do you go to when stuff happens?
I think efficient planning is necessary. Maybe the most stark picture that happened to me last year during the hurricane was, remember those elderly people who were like waist deep in water down in Florida? And you were like, well, that is the worst planning I've ever seen. I mean, I guess maybe they could have said, we don't think it was going to be that bad, but okay, well, if it is that bad, what's your plan B? And there clearly was no plan B. So I think some upfront, when you can, and if you can, and if the resources are there, really would be helpful.
And to your point about, you can use the data to prioritize. So in Katrina, they tested looking at Medicare data around durable medical equipment for folks that had that plugged in, and you could then drive emergency response to those folks. And when they did the exercise to validate the data, it validated at 97%. As they went to each of those homes and places where folks had that equipment.
I'll just make one comment, but I'd like to open up the floor for questions. There are microphones on each side. But I think your points, so from my vantage point, I think one of the things that we've seen is that there may be plans, but they happen in silos. And so this idea of having kind of a community incident command structure, or having the awareness of what the information is as it relates to which patients would be medically fragile or most dependent, and then allowing the community to fall into emergency management as opposed to having emergency management happening separate from the communities would, from my perspective, really move the needle. First question?
Thank you. Willarda Edwards, internal medicine in Baltimore in private practice. I really appreciate what you're saying with respect to partnerships and how we're really trying to get into the community. And I really like the fact that you gave a demonstration of what the SUNY is doing with addressing the social determinants of health. But when we start talking about partnership as a private practicing physician in the community, I hope that you won't forget about those 40% of those of us that are in private practice as opposed to in group practices or in hospital settings, and what we might do in terms of getting and being in part of the community and communicating to them about what's happening in healthcare. The Abilify, I'm sure that most patients might be concerned about whether or not it shows that they've eaten pizza. But those of us who are in practice with these patients on a daily basis, we want to be part of that partnership and addressing the social determinants of health. Hospitals can help us with the nutrition, the education, the social services that we don't necessarily have in our private practices, but we want to make sure that we're included in addressing the health disparities.
Thank you. In the interest of time, I'm just going to go to the next question.
Hi, Deepak Mittal. I'm a transplant surgeon from the south side of Chicago. Dr. Bhatt might know Christ Hospital. So I moved there from Rush University Medical Center after 15 years there in transplant. And I'll give you a little case study. I just transplanted a young African-American lady. And after the transplant, my social worker almost killed me because this woman has no money for food. And who's going to pay for all this? And she needs a new house. She's got several year-long wait list for Section 8 housing. She had no transportation. All the families disappeared suddenly who came at the time of transplantation. So, unlike the British health system where I worked in the past, where it's cradle to grave and it's creaking under the cost of paying for these new drugs, it's a big problem in that we're taking people off of dialysis, giving them a transplant, and new lease on life. But how do we fix the rest of it? Who's going to pay for the medication? So it's a problem, and I really don't know how to fix it.
So I would say, and there are a number of different examples in which I think organizations are understanding what assets they have and what relationships they can draw on, and systematically trying to address some of these determinants of. So the payment part of it can be hard. Finally, so you have community development financial institutions, or they're redesigning community benefit and how they think about that, or employers are getting in to help. But this is a question that the field, I think, struggles with on, what is the responsibility to and what is the responsibility for? And one of the biggest issues that we have is affordability, that the cost of healthcare, the out-of-pocket for consumers, is continuing to rise. And so we've launched something called the Value Initiative that helps hospitals and health systems do their part in trying to address the issue of affordability. Again, there's a lot of stakeholders in that environment that have to engage, and so it's also facilitating some of those conversations and actions.
Good morning. I am Dr. Joya Kriya-Perry. I'm the Secretary of the Board of the National Medical Association. And this question is actually for Dr. Carter. I was so excited when you said that within 5 years we would have our medical records, because in my previous life, about 10 years ago, in New Orleans after Katrina, as a clinical health director, I got to meet with Jeff Emelt, and I asked him, how do we get our records to ourselves? Like, I remember, I'm old enough, I might look young, that we had debit cards and we'd have to drive around to find the one that matched the symbol on your card. And at some point, regulation said, y'all all have to get along, and people can have their own information and have a card and go wherever. So now I can go to Europe and use my same card, not much my same community. How do we do it in the United States? And his answer to me was, well, there were only about 6 companies. Now you have thousands of companies that do EMR, so getting all of them herded together so that you can agree to have interoperability is impossible. So tell me why you're optimistic that we're magically going to get all these companies who make money off of us being siloed to have us own our own medical information.
Well, I'm an optimistic.
Me too.
And I actually, I'm not a doom and gloom with regards to data. I think that it would be easy, and especially given the times that we live in, that you could just sort of say, well, this is really going to just be bad. But I think that I just don't perceive that it'll be that way. And one of the reasons why I don't is because everybody will benefit from the world that we're moving into. Let me tell you about the EMR piece that you're describing. So yes, we have, I think there are hundreds of companies that have EMR, but I believe there are about 4 or 5 who are the predominant electronic medical records folks. And there are challenges with having those because, again, they don't speak to each other. And so when you have one versus the other, it's really a difficult piece. But the reason that I'm optimistic is that where everybody will go is, let's say we decide upon that there are 100 pieces of data that we need, and we can get those 100 pieces of data no matter what the medical record is. So as long as we can define what information we want everybody to have, then when whatever record it's in, it'll be downloaded into your system and you'll just pull the data down. So we're moving into a world where you're agnostic with regards to how the data is collected. You just need to understand the data fields, and you need to then be able to extract those data fields from wherever. And I think that and we are very, very close to moving in that direction. Now, the challenge, and we actually, before we started working with Proteus about the embedded chip in the tablet, we actually had considered how could you provide folks with their own records and what would you do with that? And we said it can't be a watch, it can't be something of value, it can't be, so we were going through, would it be a necklace, what would it actually look like? It's probably going to be, and who knows, but it's probably going to be some sort of stick, like you carry all of your information around, but you have to make sure that the patient would have it at all times, and that I think becomes the real challenge, because when you get to the emergency room, you'd want the people there to know how are you carrying it, and how do you use it, and where do you put it, and what information can you download from it. So I think there's still work that needs to be done, but I think 5 years.
I think there's some progress being made on it through application programming interfaces and bolt-ons that, Epic, for now example, can pull from all records in organizations that have Epic. And there are other approaches that are being tried, but I think it's going to take some time.
We started to see as a best practice as well that during disasters, a lot of these companies will kind of use that as an opportunity to release some of the interoperability guards as a test of what it looks like. So I'm not as optimistic, but I'll take it. Next question.
Very good. Good morning. My name is Jean Drummond with Healthcare Dynamics. And when I think about this work, I think from policy to practice. So if we think about MACRA, and certainly, we're a part of the Transforming Clinical Practice initiative, want to just welcome any doctors that are needing any assistance. We have our partners here, Dr. Tran and Dr. Rios and the NMA. But when we think about this, as we've been working with clinicians, building sustainable practices, the major challenges clearly go back to collecting real data, also around the social determinants of health. And so as we think about building sustainable, communities, what would you say is one of the, if you say one-word answers, could be the greatest focus that we need to, the greatest place that we need to focus our resources to really rebuild our communities? One of the things I'll just share, we've created a tool that collects the real data, the social determinants data, and chronic disease around diabetes. And it's proven to show that we are changing the lever as it relates to, if we can go upstream, we can definitely reduce ER visits and hospital utilization. So just asking, what would be one-word answer that you would say, one-word answer, that you would say is our greatest place to focus as we try to redesign, because we've got to strengthen our communities in order for MACRA to succeed?
One word. No qualifiers.
I don't know. I was gonna say children. Yeah.
Okay.
Yeah.
Any words?
My word would be sleep.
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 Okay.
And there is.
Got 2 words.
No, I'm telling you why sleep. I'm telling you why sleep. Because I think that the power and the relationship of sleep to illnesses, chronic and acute, is becoming more clear.
Okay.
And so if we understand, we have an epidemic of people who get no sleep or who are incredibly tired. And the question is, what is that doing to your immune system? What is that doing as far as inflammation through your body is concerned? How is it impacting you? So I think that, to me, a major determinant of health would be sleep.
And I would take everything that William said and just replace sleep with stress, because I think looking at stress, whether it's racism, social stress, financial stress, that has an impact on whether or not you're going to take your Abilify, microchip or not, go to the physician. So I'd say stress.
So I'm just going to take the last 2 questions so we can answer them together. Ma'am?
Hello, and thank you for your presentation. My name is Ann Simpson. I'm an internist geriatrician with the University of New Mexico, but a former K through 12 teacher. And as I listen to the conversation and hear oftentimes the term social determinants mentioned, and if we go back in the literature when they first started addressing social determinants of health in sociological literature 40 years ago, it was very clear that you have to think about education starting with the very young and that incorporation of the community. And although I've heard people mention community as stakeholders, I haven't really heard anyone articulate how you include the teachers and the students in those lower grades. So when you do just address this, if you could, I'd appreciate it. Thank you.
Thank you. Next question.
So I'm Lamar Hasbrook with the American Medical Association. It's good to see everyone, and I enjoyed your panel. So I'm going to harken back to my days of residency, which is in the patient handover. So when a physician's on call to take the list of patients, and it occurred to me as I was listening to you guys talk that when the on-call resident took the list, there was what we called a warm handover. So there was not only a list of the patients and their active problems and things, but there was that personal touch in walking the oncoming physician through, real life issues and things like that. So one of the things that I'm concerned with that we may be getting away from is the humanity of medicine, that warm touch. Now I could have followed the 40 patients that I had to take care of overnight by looking at the computer, but something would have really been lost there in just the exchange of the information without the exchange of the human touch. So I was at a meeting last week at the Joint Commission Physician Leaders, and one of the speakers said, one of the ways that medicine has lost its way is because we monetize medicine. There is no mission without margin, is what he said. And so in framing this issue, my question is, what's really driving the innovation? Is it mission? Or is it margin? Because I think that speaks to the stewardship, the security, the accountability of the data, and to our last speaker, the involvement of the community. So I just want us not to lose our way and to put that to the panel. Thank you.
So final remarks on mission or margin or education.
Hello, Lamar. We did residency together years ago. I think you're absolutely right. Sort of that exchange between physicians and providers about that patient, understanding who that patient is. And I think our mission has to be driven by community voices. For instance, the project that we did looking at women with disabilities, we thought it was a problem with access, just giving someone an insurance card and then they would be able to get a mammogram. But it was in speaking with them that we came up with innovative approaches to actually getting someone physically through the door. So I think we cannot achieve our mission without really listening to what matters most, and that does require the human interaction. So that's what I was talking about, complementing some of the data that we're collecting quantitatively with voices. So listening to the voices, I think, is an important driver of the mission.
So, I would say on the issue about education, that it's critically important, and that's why I said, children, that from birth to when we keep going, we have to invest in them and their health, and teachers are a critical part of that, and they're a critical part of this Chamber for Health notion. And we see school-based health centers which can evolve, but that the intersection of health and education continues to be critical important, and I think we've got to continue to accelerate and develop that in different ways. To Lamar's question, I think it's mission, but I also would say innovation is not just the shiny new object, right? The innovation is doing something differently to get a better result. And so we're seeing a lot of that happen if health is at the center, if we're trying to, the mission is to improve the health of people and communities. And then I would say that we're in a time in healthcare now where the workforce is losing their connection to purpose because of burnout, because of the challenges and the stressors that impact them, whether it's the trauma that they deal with respect to their patients, or it's the challenges of the environment. And so the more that we can do to help reconnect our workforce to purpose, I think the better off communities will be and patients and families will be in trying to drive towards mission and then being able to innovate around that.
Dr. Carson, last words?
Yes. As the child of two public school teachers, I think anytime I speak, I'm grounded in knowledge. So, so to me, I take that as a given. So I think that to answer Lamar's question, I don't know, but I heard your name, and that clearly we all have to use our knowledge, our thinking processes to really put clarity around the situation that we find ourselves in. The $800 million that I talked about that was going to venture capital in the healthcare space, why is that happening? Let me tell you why. The reason it's happening is because we have a broken healthcare system in this country, period. So if we could fix healthcare in this country so it was universal, everybody has it all the time, then and I always get in trouble as a pharmaceutical person when we say that out loud, but I just have to tell you that that's the problem. And if we had a working, functioning healthcare system, you would not need to see these $800 million of Band-Aids put on to try to make the system work.
Please join me in thanking the panel for their remarks this morning. You all have been wonderful. Thank you all.